introduction. I don't know if Charity is there and she can hear us.
I think she's on. She has logged in. Maybe if she can hear us, she can say a word.
Yes.
Charity.
Hello, everyone. I'm so sorry I had the technical challenges, but I'm here now.
It's okay, Charity.
Charity?
Welcome. And maybe Frederick, before you pick up, I'll request everyone to mute their microphones.
Okay.
And then now on to you, Frederick.
Okay. Okay. Good morning, everyone. To begin with, I will appreciate if from your end you are able to mute your mic. We are able to minimize background. Fred Kiserem, your mic was on, so thank you. Okay, so there's still a little of some background noise, but it's minimal. So thank you everyone for joining. I understand the rest will be joining as we move on. A quick one before I give Charity an opportunity to proceed with the presentation. This is our fourth session, and today we will be taken through mental health as one of the NCDs. So I'm looking forward to learn a lot from this presentation as everyone else. What I want to bring to your attention is we will be having a press conference on Tuesday next week. This press conference has been put together by a support group of persons living with NCDs under NCDAK. So they are coming together and they want to just highlight, their experiences and some of the things they have had to go through, especially during these COVID times. From the previous presentations that we've had from diabetes and the rest, you have noticed that the presenters were keen to mention that persons living with NCDs have been on a risk once maybe they get infected with COVID. So you can be sure they are at a point where they are so concerned about their lives and everything that is happening right now, and they're just wondering if out there's somebody who really can hear their plight and just highlight it and see how best they can be supported. So this is a call to all of us in the media. You might want to, just get an opportunity to join that press conference. It will be done in a form of a webinar. And because still most of us are still joining in, probably by that time we are having that press conference on Tuesday next week. I will share the details again on our group, so that any media personality who would wish to be part of that press conference to just get a highlight of the things that the support group for persons living with NCDs will be presenting, then they will have an opportunity actually to get that first-hand information. So as we proceed, just put this in mind that on Tuesday next week, we will be having a support group meeting with persons living with NCDs, as they share their plights and highlights of what has been happening all along during this time of COVID. especially with those living with NCDs. So that is a great opportunity for all of us. I know we can be able to pick, angles of story for the news or for the features. And there are some of us who have been requesting me to connect them, whether with persons living with NCDs, to highlight on their flights or stories. And I think this will be an opportunity as well. So I will just take a minute towards the end to give more details on the same. But right now, I want to take this opportunity to welcome everyone again, from the media personalities to our team at NCDAK, and also to take this opportunity to welcome Charity, founder of Tunawiri, as she proceeds to take us through our presentation for the day, which is about mental health. So, Harrison, if I think from your end you don't have anything else to add, then I hand it over to Charity to continue from there. Charity.
Okay. I hope that you can see me.
We can
Hello.
see, I can see your
Okay.
presentation, Charity. I can hear you very clearly. Yeah.
Okay. Okay. Sawa. Thank you. So thank you everyone for being here. Thank you for honoring our invitation. My name is Charity, as you said. I am a user of mental health services with lived experience with bipolar, and I am a caregiver to a family member who does not wish to disclose their status. I am with Tunawiri CBO, and we work with mental health in the criminal justice system. Currently, we have a program at Mathare Hospital Maximum Security Unit, and also in Yatta Prison, where we are trying to improve mental health, manage its determinants, and so on. I'm also a member of the Task Force on Mental Health, representing users and caregivers. And with NCDAK, I am an active member and a global advisory committee. I'm in the global advisory committee. So today I would like to talk a bit about mental health and in relation to the media. I have a bit of experience. My involvement so far has been that when the task force started, as patients, we felt that mental health concerns us and we should have a seat at the table. So we, made some posters talking about how we as Kenyans should fight for a place, and how we as patients and caregivers, we need our psychiatrists, yes, but there is life beyond the hospital. And so we did social media engagement, and then we approached members of the media. We did a press conference, especially on the issue of inclusion. And I think then is when I actually realized just how powerful media can be, because in 2 weeks, we were given a seat in the task force on mental health. And so I appreciate everything that you do. I have better appreciation now, and I hope that we can find a way to support each other better, to be ambassadors of each other better. I think the challenges I had during that press conference is I was not really prepared. It's not something I had done before, so I didn't know what exactly to do, how to read. There are stations that confirmed, 2 days before, 1 day before, an hour earlier, but didn't show up. There are stations who didn't show up but asked for the clip, and that was exciting. My second media interview experience was now just after the press conference. We were invited on NTV together with the chair of the task force. And so the discussions we had were about inclusion in the task force. But once we got there, the program had changed. So it took me a little bit off guard. The second time was last week, a media interview with K24, mental health and COVID. I prepared very well. Since I was representing the task force, Ministry of Health, went through the answers, edited, and I was very ready, practicing everywhere, including as I was working there inside my mask, and then I get there and the topic has changed. So that is something I'm to get used to. And when we get to the questions and answers, even as you ask me questions, I would like you to help me understand how best to deal with the issue of change when we come to the interview room. Otherwise, we really appreciate you for being here. Thank you for giving us the opportunity, especially as patients and caregivers, to influence your work. So I'd like to start with mental health and mental illness, because currently we have a lot of confusion between the two. We hear people saying, Charity akona mental health. You know, when someone is trying to say that I have a mental health condition. And so I felt it's necessary for us to get to know the difference between these names. So mental health, according to the World Health Organization, is a state of well-being which a person can cope with the normal stresses of life, work productively and fruitfully, and be able to make a contribution to his or her community. Whereas mental illness or mental disorders are a wide range of mental conditions that affect one's mood, thinking, and behavior. So the key words there are mood, thinking, and behavior. So we have several conditions under what we call the psychiatric table. And our psychiatry in Kenya is borrowed a lot from the American Psychiatric Association. So mental illnesses are many, and they include schizophrenia, depression, intellectual disabilities, which covers quite a bit in terms of autism, cerebral palsy. Cerebral palsy is developmental. Intellectual is autism, Down syndrome, dyslexia, and so on. And then we also have substance-induced disorders, which we say are disorders due to drug abuse. We have depression, we have psychosis, epilepsy, child and adolescent mental and behavioral disorders, which is an umbrella for many more. Then we have dementia, and Alzheimer's is one of the categories of dementia. And we also have suicide, either suicidal ideation or suicidal attempts. So in the notes, we are going to share, as we share the notes of the class, we are going to share with you the 7 prioritized conditions by the World Health Organization, because there are very many. So every few years, the World Health Organization chooses some to give priority to in terms of finances and so on. So you may have heard of this before, that 1 in 4 people in the world will be affected by a mental, neurological, or substance use disorder at some point in their lives. But I don't think that figure really touches home until we look at ourselves in terms of how many are we in our family, how many are we in our newsroom, how many are we in a matatu, how many are we in church, how many are we in class, and so on. Because if you look at it that way and you just count, I am 1, then there's 2, 3, 4, and then another 1, 2, 3, 4. It means that while we are here as, I think you said it's about 35 people, then that means we have at least 6 people. Of course, it doesn't mean for every typical 4 people, but for purposes of context, it means that at least 6 of us have a mental health condition or a mental disorder. And that could be diagnosed or undiagnosed, but it helps to bring it home wherever you're watching from right now, because whether you're at home or just think of 1 in 3 people in this plot, 1 in our class, 1 cameraman out of 4, and so on. So the other thing I thought would be important to include is the issue of happiness. because right now the world is looking at happiness as an index that can be attached to our mental health situation in our country, or being able to quantify. So we have a happiness index that is used to measure collective happiness as a nation, and it was started by the SDG group, or rather during the SDG conversations, and then later the UN General Assembly actually requested countries to be able to be looking at the happiness index of the country, so that it is so that the focus is more on improving mental health versus addressing disease. Because we in health, we are very focused on addressing disease while we should be doing wellness management. And so I hope that answers your question, if you wanted to understand mental health and mental illness better. But also, in case you have any questions, please put them on the Q&A or in the chat, and then we can address them when we finish. So there was one of you had asked about risks, and I just wanted to mention that in mental health or mental condition management, we are moving towards looking at determinants more, and so is WHO, more than risks, because then all these determinants together and in a very complex way work towards providing the risk to mental health conditions. So our mental health and many common mental health conditions, and in this case I'll be referring to the 7 prioritized by WHO, are shaped to a large extent by our social, economic, political, just a minute. Let me just ask Harrison, which okay, Sawa, it had gotten off screen. So our social, economic, and physical environment. And social is very wide, because then even our political climate, because I was actually discharged from a mental health facility just 3 weeks ago. And one of the gentlemen I was with there actually attributed his substance use to one election period. And by the next election period, it escalated into mental illness. And so I mean, the social, economic, and physical is very wide, but in real sense, it is our culture, it is our economic status, it is our family dynamics, it's everything that contributes to that. And so I've just listed a few, especially in issues of unemployment. I know I had a relapse after I was retrenched 5 years ago. Poverty is a big one, and that's why countries, low and middle income countries, have higher levels of mental health conditions. Insecurity, which is very huge in terms of areas of conflict and also for our security personnel. Gender-based violence, which is unfortunately on the rise during this COVID season. Low literacy levels, because actually I just spoke to Dr. Chitai this morning, and he mentioned that health literacy is the biggest social determinant of health. And so that means even for mental health literacy is the biggest social determinant of mental health, because how much we know determines how we are conscious to be able to prevent and so on. Deprivation, homelessness, poor working conditions, our jobs also, because I know even as media personalities, with the trauma that you face on a daily basis, it impacts on your mental health and puts you at risk of mental health conditions. Social inequalities, disparities, and so on. So these are just some examples to give context, but all these determinants contribute to our mental health as individuals and collectively as a nation. Next slide, please. Okay, so what is our access to mental health services at the moment? And as I speak, I would just like to mention that I'm speaking as a patient, I'm speaking as a caregiver, I'm speaking as a Kenyan, and also also as someone who has participated in the task force process. And so when we're looking at access, we're looking at quality infrastructure, adequate and qualified human resource, health products, equipment, and technologies. That's the way we look at it in the health sector. Currently, we mostly know of Mathare National Teaching and Referral Hospital, but many of us may not be aware that we actually have level 4 facilities, 26 level 4 facilities which have psychiatric units. And many members of the public, and I think even media stations, are probably not aware of that. And so because of the coverage of Mathare so much, what happens is people end up thinking it's the only place, and we have people living Nyeri PGH to come all the way to Mathare, and then Mathare has to refer them back there. If they are used to now the nurse at Mathare, they don't want to go to another place. Or if someone is a teacher in Nyeri, like I have a friend who's a teacher in Nyeri, then she doesn't want to run the risk of meeting parents of her children who may be staff members at the facility, and so on. So we have 26 level 6 facilities. Unfortunately, not all of them are resourced. So you'll find either they don't have medication, or they don't have a proper, adequate running unit in terms of human resource and so on. But we do have 26, and one of the things we are doing is for advocation. We are advocating to have mental health facilities at every level, so that if there is a clinic near you, you can access mental health services. So this level 4 is what is there now, but what we are pushing for is community-based services. So unfortunately, based on the facilities that are there, we were able to find that 75% of Kenyans are not able to access mental health care, and that's a very big a very big percentage that we need your help as the media to be able to, because the more you make noise about it, the more we are able to get the financing and so on. So Mathare National Hospital, which is my hospital, by the way, is a whole 110 years old. It's dilapidated, it is old. There are buildings that are condemned by the Ministry of Works and cannot even hold people because they can crash at any point. And I am happy to take you for a tour at my hospital so that you get to see what is there. Because I think many people, both in the media and even organizations working in mental health, not many have been to Mathare to understand what is there. And being a national referral hospital, it sets the standard. And one of the biggest recommendations we have as a task force is that Mathare needs to be rebuilt. Period. It cannot be renovated. It cannot be improved. It just needs to be taken down phase by phase and rebuilt. Is the only way. And we need you to help us make a lot of noise about that, because Mathare needs to be rebuilt. Once it has the right standards, then it becomes a benchmarking facility, even for county hospitals. And the more you're able to cover county hospitals and even community models, like we have Family Health Center, which is running at Kabete, Kangemi, and somewhere else, as a community-based model. The more we highlight such, the more people take away, are able to see that Mathare is not the only place where they can get help. So we are looking at implementing community mental health services at county level, and hanging on to or putting emphasis on the deployment of the infrastructure, human resource, and multidisciplinary mental health workers. Because I think many people assume that if someone has a mental illness, all they need is medication. But even when you look at the report, the first thing that we've talked about in mental health services is that some people are able to deal with their mental health conditions purely on self-care, because all our conditions have a spectrum. So there's there is high spectrum where, you know, the what do you call them, symptoms are more, or the burden of disease is high. But we also have lower level, and that's why it's 1 out of 4, because not everyone needs psychiatric services. Prevention, and that's why we are saying knowledge of health is important as a determinant, and as the biggest determinant. When you know what it is that affects your mental health and you're able to manage those triggers, you can prevent getting to the spectrum where you actually now are dependent on medication. And so that is why mental health literacy for you, the more you're literate as journalists, the more we are literate as Kenyans. And so we are also looking at KEMSA, who are very notorious, extremely notorious for not fulfilling their mandate. KEMSA has first generation drugs that are over 100 years old, that have been passed by technology and improvements over time. And so and like when we did a visit as a task force to KEMSA, we found a pregnant woman climbing the fence, and the staff was so tired of going around trying to calm her down, and there was no single injection at a whole level 6 national referral facility. And we were angry. We were very angry. And when we went to KEMSA, they didn't even seem to realize that that is a problem. They were wondering, why do we have an issue with that? And we had to, they only acted after we went to the PS and made a lot of noise, and then now medication was availed, and now it's back to not being there. And so we need you to help us to push KEMSA, because very many organizations, very many institutions have pushed KEMSA, but things are not happening. We have a very good mental health essential drugs list that's advised by WHO and has been passed within Kenya as a right list. But I think out of the ones that have been added for many years, there's just one called olanzapine. So if you go to Mathare and they tell you, we even have olanzapine, that is a very small excuse. That's a drug that is 10 shillings, and that we even have to pay for, they cannot avail for us. So we need pressure on KEMSA to provide good drugs. And by the way, personally, me as Charity Muthoni Muturi, when I was unable to, because there is second generation drugs. Okay, first generation are the first ones, and then second is the better ones, third, and so on. So we have very good second generation drugs in Kenya. Provided especially in private clinics and pharmacies, but they are expensive. I personally cannot afford the drug that I'm supposed to take on a daily basis. And yet, when I got an alternative at Mathare, it affected my kidney in 3 months. When I was going to my people at Mathare Maximum, they were telling me, "Hey, mwalimu, umefura miguu, umefura macho." So I tell the doctor, she sends me for a test. And, you know, these people start giving me counseling, you know, before they give me the results, and I was scared. And it's very unfortunate that that is a drug given by Mathare Hospital. Very, very unfortunate, and it's unacceptable. So please help us push for that. Next slide, please. Okay, so I'll not spend a lot of time on this, but it's just to help you understand what I mean by community mental health services, which is where the world is moving to. So we actually look at it from the bottom up. So at a personal level, we need more self-care being implemented at a personal level, where we are able to prevent stress, employ you know, good habits in terms of at least having 8 hours of sleep on a daily basis. And media people, you need to take this seriously. Lack of sleep is one of the biggest triggers towards mental illness. Having a right diet, pacing yourself, so not overworking too much, having the right balance of work and family, and so on. I have a self-care slide at the end, which I will leave with you. And then we have informal community care. And this one, please, people, do not misquote me. Informal just means that, you know, before, in fact, there's a psychiatrist called Dr. Mutiso with Gilead Care, and he was saying that in Kenya, it takes for most people to move from having a symptom to getting to the psychiatrist is 10 years. 10. Why? Because it is assumed to be a character issue, and I've experienced that myself. Or it comes through what we call psychosomatic symptoms. So I have a headache, but it's not really a headache, it's a psychological problem. I have hysteria, but it's actually a psychological problem, and so on. And so I go to specialist A for the ears, specialist A for the eyes, and so on. But these people are treating a psychological issue without knowing. So even for me, I mean, I went to so many specialists for a long time. And now is when I'm able to see, by the way, it's true. This, when I have this kind of stress, I have this kind of physical pain. And so we are saying informal is the traditional healers, because in our rural setting, most people are taken to traditional healers. In fact, most of our clients at Madare Maximum, their condition blew up while they were receiving care with traditional healers. And so there's traditional healers, there's faith-based healers or religious leaders, you know, where when you have a symptom of feeling like you are a god, either people now start following you as a religious leader, or they start what is it called? They start sorry, a message has come in and taken me off where was I? Informal community. Yes, so someone is either at a traditional healer or in a religious institution being prayed for. You're having psychosis, which is seeing, hearing, or feeling things that are not real. But now the religious leader looks at that as a vision or something like that. So you find that is informal community care. But what we are saying is we need, for our traditional healers in rural areas, our religious leaders, to be informed of basic mental health understanding. In fact, the World Health Organization had been doing a gap. They were looking at what are the gaps of mental health or in various places. So especially for low and middle income countries, World Health Organization realized that as much as we have few psychiatrists, that is not our biggest issue. Our biggest issue is lack of basic understanding and referral. Because then we have police who are dealing with people with substance abuse issues, stealing one thing or the other to be able to fund their habit, or you know, petty theft and things like that. But this is actually a mental health issue that is now, you know, taken to the cell and taken into prison. And if this police officer was able to understand the basics, then they would be able to take this person for care instead of taking them to the prison. Or where, like in our constitution, suicide is criminalized. So we end up again in a cell. Or where this religious leader is able to tell someone, oh, okay, it's true, there are visions. However, I feel that what you are experiencing should also be looked at by a psychologist, you know, because it's easier to send someone to a psychologist than a psychiatrist, trust me. And so then what we are saying is that we have informal care, and we cannot deny that, because people are at the traditional healers and religious leaders, but we need to empower them so that they are able to refer to the Ministry of Health. And we don't want a misunderstanding on this for the media to say that traditional healers can heal mental health. No, people are going to them, we cannot deny it, but we want to work with them to understand. And there's actually a successful model at Makueni, where the African Mental Health Foundation has worked with traditional healers to be able to understand what it is, and they actually refer to the hospital. And so that's a good one. So primary health care is where many of us go for treatment, and that is the small clinics and dispensaries, but they do not have mental health understanding or human resource, and we are saying that this needs to be improved there. And now the optimal mix is in just above that, where we have psychiatric facilities in general hospitals, so that's Madari and the county hospitals, but also community mental health services. We have even worked with community health workers, not volunteers, workers, to be able to identify and refer, but also to teach people basic self-care, be able to prevent, promote, and so on. And then the top, which is what we are used to, is the long-stay facilities within psychiatric hospitals. Next slide, please. Okay, so we had been requested to talk about, and I'm sorry for the word, the spelling errors. So I was requested to talk about COVID-19 in relation to mental health, and I think for many of us, we've seen the impact it has had on us personally. So where we are experiencing a lot of uncertainty and disruption of what we are used to. As communities, we have a lot of fear of contracting the disease, whether personally or for our family friends, or our family or friends. We have what the fear of contracting, but also the culture change. Because as Africans, we are used to greeting, congregating, and what else? And burying, which we cannot do the way that we would want to do in an honorable way. And the other thing is, for us who have pre-existing conditions, just like I said, I've just been discharged from a mental health facility, because we have higher susceptibility to stress. It means that while even the kawaida person is now at risk of mental health conditions due to the stress of COVID, we with pre-existing mental conditions have even higher susceptibility to illness. And so we are experiencing a lot of stress. I'm just giving a little bit of background, then I'll get back to the slide. So we are experiencing a lot of stress psychologically, socially, economically.
Hi, Charity.
And that it's very difficult for us to deal with on a daily basis. And then we have our frontline workers, and I'd like to start with you, our media people, our front workers. We appreciate you, we celebrate you, and we need you. And so the trauma that...
Charity, can you hear me?
Yes.
We had lost you at the point where you are speaking about how you are experiencing stress socially. Then I think
yes, now I can. So please repeat.
We had lost you at a point where you are speaking about how people are experiencing stress due to COVID-19. I think you are saying a statement about experiencing stress socially. Then you disappeared from there.
Oh. Okay, thank you. So I was saying, on a personal level, we're experiencing uncertainty and disruption. As a community, we are also experiencing uncertainty and disruption. And then it's extremely when contracting the illness ourselves or by our family members. And also the fear that comes through having too much information. Some which is valid and some that is invalid. And then we are experiencing culture change, where I mentioned that as Africans, we are used to certain things like being able to congregate or greet each other, physically, and burying our dead in an honorable, what we feel is honorable for us. And so that has affected our way of doing things, both in our country and across the world. But what I was also saying is that we with pre-existing conditions are more susceptible, very susceptible to relapses due to stress. And so even as the wider society experiences mental health challenges, and actually the Ministry of Health, Mental Health is also looking at how do we then deal with the mental health crisis that is inevitable during COVID. But this is to say that we with pre-existing conditions also have we are more susceptible, and so we need more services. Okay, so the last thing is, I was saying frontline workers, with you as the media as our lead, you are experiencing a lot of trauma. on a daily basis as you report. I'm sure the stress levels are higher even in your working conditions. We are having people being laid off from media stations and so on. And I mean, we as persons with lived experience do not want to welcome you to our world. So we need you to take care of yourselves, put yourselves first. Even when we need information, we need you more. And so what we are saying is our frontline workers, you as the media, health workers and others, are at risk of mental health conditions due to their trauma, and something needs to be done about it. So what COVID-19 has done is that it has highlighted the gaps we have in healthcare. It has highlighted prevention that is lacking, promotion that is lacking, management and aftercare, because our issues don't end when we are treated. If we leave the hospital and we have an economic issue, like when we were doing determination last week, I was saying, last week on the task force, because we have webinars every Monday and tweet chats every Thursday, I was saying that if I leave the hospital and I don't have rent, I don't have food, I don't have money to afford healthcare, then I'll keep coming back to this same hospital while my need is socioeconomic. So we need our health systems to think through aftercare. Otherwise, we'll keep treating diseases instead of managing wellness. And so as a task force, by the time our mandate ended, our official mandate ended on 28th of February. However, there was the change of guard from the previous CS to the current CS, and so we only launched a few weeks ago, and so we felt, in fact, it's we as patients who requested the task force. Why don't we do something to acknowledge COVID-19 and probably to give insight to how this should be handled in future emergencies. And so because of that, we, the task force has agreed and done a postscript on COVID-19, which is in the report. And now the things that I'm talking about are, there we've talked about implementation of the task force report recommendations as that will contribute to reducing the impact of COVID, but even to manage mental health in the long run, because there is life after COVID. And so what we're saying is all the issues that we have raised, and I'll request Harrison to share the recommendations with you, is to say that when we improve our medication, when KEMSA provides the right drugs, when services are available at community level, of course, even now, even accessing that Madari for many patients has been a problem. When we have good staffing, when we incorporate and integrate psychosocial support, because I need a psychologist, and right now psychologists are 3,000 to 8,000 an hour, which I cannot afford. And what I was affording at 500 at Madari is no longer there at a whole level 6 facility. And we have so many qualified psychologists in this country who are jobless, and the only way that majority of Kenyans will be able to afford psychological services is when the government takes up the bigger cost. And so we are also, just like I said, we are experiencing more challenges as persons with pre-existing conditions, and we're saying that the management of COVID-19 means that we improve the pre-existing, and even telecounseling. We had pushed through you, and we are very grateful to the Nation press for giving our story. We are pushing for the telecounseling line, which was televised, the 1199, and it's a facility that you can use as journalists as well. The economic hardship that we are facing is also challenging our mental disorders as a country and globally. And so we have, given recommendations of the same thing that we have as general recommendations for mental health improvement. We'll work towards improving COVID. Next slide, please. Okay, so I'll not go through in detail, but this is what I'm saying is that improving COVID means improving the same things that we have recommended as a task force. You'll have this in your notes so you can go through, but generally we are saying we need a commission to manage this long term, because mental health will require the Ministry of Education, because we need children to have it in the curriculum. We need insurance private insurance to stop having retrogressive policies and excuses not to give care. We need the NHIF free cover for people with mental health condition. We need, and so this commission will be able to manage that in the long term. There's the issue of addressing it as an emergency of epidemic proportion, so that it is dealt with better. Madare being rebuilt, multi-sectoral approach, which I have mentioned, and just having a system like we did with HIV, improving finances, regulating institutions. In fact, it's very unfortunate that rehabs are actually under, and I think NACADA are under the Ministry of Interior. Yes, yet this is a mental health issue. So rehabs actually are not regulated by the Kenya Medical Practitioners and Dentists Council, which is ridiculous. Number 8, please. Okay, sawa. There is 8 to 15. It will be included in the things that in what you will receive. So it's the issue of having it in the curriculum, but also it has now been passed as a recommendation that we as patients and caregivers have to be in every policy table. So even that commission, and you can help us push to even be in the board of every hospital, even if it's one NCD patient and one patient for communicable diseases. And so I'd like to say well done, our media people, because you have prioritized mental health and kept it kept it at the top of our priorities as a country, which is what is helping us be able to do all these things. So thank you to you. And without expert guidance, you have invested your own personal time, your efforts to understand the complexity of mental health, and we appreciate that very much. But what we are saying is we need some things to improve. We need a bit of more due diligence so that you're able to give truthful information, accurate, empowering. That is a very big one, because unfortunately, a lot of media stories, highlight us as very dangerous people, lazy people, unpredictable people, violent people. And do you know most of these people that you put in the media, so and so has slashed someone 22 times, they must have a mental condition. And when they are checked by a psychiatrist, they are found to be okay, because there are other issues that make people kill. And even Madare only has 300, and the majority of them have been there for decades. And so, and that's where, those who are found to actually have committed a crime due to mental illness are. So you're misrepresenting. I don't blame you, but it's important for you to know that you're representing us in the wrong way, and it pushes stigma more. So people are now going to psychiatrists and saying, if you're going to diagnose me with depression. I don't want anything else. So you please provide empowering information, equitable. Years later, we are still only hearing of depression and suicide. Yet we have autism, cerebral palsy, ADHD, epilepsy, anxiety, bipolar, schizophrenia, epilepsy, and many more. And so we need a bit more equitability, but also even in social classes, pick people in different social classes, people from different areas in the country, and let it be purposeful. Because us as patients, we are always called to do stories, but we don't see the immediate impact, or rather, it doesn't directly influence policy or leadership or change. And you can help us, because I may not know every patient who's coming to be with you, even if we are trying to empower patients in advocacy. So try and work together with us to make it purposeful, that at the end of that program, the government is pushed to do something. Religious leaders are pushed to understand mental health. The cameraman is pushed to take care of his mental health. So let it be a bit more purposeful and try to do no harm, because the perceptions you create to people become truth, because people are like, hey, that one was on Citizen, that is the truth. And so you can help us to manage impact. Please, we need you to stop giving the perception that we are violent, because it is not truthful. We need you to provide the perception that we have successful lives. We are able to overcome. But beyond that, we are able to influence policy and even be in boards in hospitals and provide good impact. So we are asking for innovative that catalyzes change, changes the status quo, including like one example Dr. Tsai has given me is when you have a 30-minute story, if 25 minutes can be more of elevating the positive thing about this. Like globally, you'll see they are now saying, hey, Kanye West has a mental illness. Who was this, Mrs. Doubtfire? Robin Williams, Princess Diana, so that it gives a different face of success, and then you give that the mental illness information towards the ends of the program or as a small segment, and then educate, please, and especially when it comes to suicide. What, like I said, media is, God with a small g. People believe what you say. So when you report suicide and show that someone used this pesticide, and you even show the body, and I was just learning that there's a time in Europe after a certain program, they had a pandemic of people just committing suicide. So when you show the means, when you show the pictures, you glorify it, you sensationalize it, you make it normal, you make it a goal, So please spend less time on the suicide itself, spend more time in educating people that there are resources for suicide. You can call 1199, or you can call Befrienders Kenya, or this is a mental illness, please see a qualified psychologist, and so on. Next slide, please. Okay. So what we are saying is we need you as our media. We need you. We need you. We need you in everything. And so we are asking, please take care of yourself. Just like we hear about the proverbial mask in the airplane, that you need to put on your mask first. So you will have this presentation, but basically self-care is looking at your physical health on a daily basis, managing your sleep. I know because editors are, up to you the whole night. Me, one of the reasons that what is this called? That triggered my mental illness was those, working on night shifts, not working during the day, and not resting during the day. Take care of your emotions, take care of your social circles, take care of yourself spiritually. Then, if you can introduce debriefing sessions, even just once a month, where even if it's media stations together, because within one media station, people, it may not be as vibrant, but you can have like a monthly debrief where you just talk about, hey, this is how I feel, this is what happened, these are the things that I saw, I am affected. Be able to talk about it. Even us, because we are not able to afford psychological services as patients, we cancel each other. We sit down, like now we are having it every 2 weeks. Due to COVID, people want it twice a month. So we just talk about our issues, and it helps to lift the budget. But I've also included the Ministry of Health and Red Cross, whatever the red poster is 1199, which you can call for free counseling. There are a few more others, so you can look up PDO Kenya, which is in Nakuru Psychiatric Disability Organization. I think Hisia also have a helpline. Thalia Psychology also have a helpline, so you can call and just talk, even in the middle of the night. So please take care of yourself, because we need you. In terms of and even just putting your safety first. If you have an interview and you know that when you do them at night you have nightmares, change them to morning so that you have a bit more time to take care of yourself before you get to sleep. Yeah, so the next one. Okay, I thought so. So we are done with what I had. I hope you've put your questions in the chat. Let's talk together. Let's help each other. Let's be innovative. We can even use comedy to put across information. We can have films, but by all means, please cover our positive story. When I say a mental illness, people start moving because they think I'll hit them, is wrong. Thank you.
On the screen, we have the questions that were asked during the presentation. So probably you could help respond to some of these questions. There are quite a number.
Okay, just put all of them so that I.
Yes, they're on the screen. I'll keep projecting from page to page.
But how many are they? Okay.
So far,
Okay.
15.
All right. I'll try to give. Wow. Okay. So let me try to give just a line to each, but we'll look at the questions again and provide more elaborate answers in the notes that we are going to give to you. So in slide 2, epilepsy is not a mental health issue. However, people living with epilepsy could experience depression due to epilepsy and the worries of getting a seizure and relating to stigma. Okay, one of the issues that you will find is different health bodies use different names. You'll find some people with epilepsy will say they are neurodiverse. So some are managed by neurologist, another by a psychiatrist, and so on. What I didn't mention is that mental illness actually qualifies as disability. And so within developmental, intellectual, cognitive, and neurological disabilities, epilepsy is there. And right now, we are moving to neuropsychiatry. So actually, Aga Khan has started a neuropsychiatry program because there is a lot of interaction between neurology and psychiatry. So that's why we've included it, because there's the 7 priority conditions, and you will find it there. Okay, difference of mental illness and intellectual disability is what I was saying. WHO has a health model, so they call it mental, neurological, and substance use disorders. So all those are considered mental by WHO. So even neurological for epilepsy is there. So what happens is now the UN Convention of the Rights of Persons with Disabilities have now categorized those mental, neurological, and substance use disorders as developmental. So you'll find some people with epilepsy saying ours is developmental. Some within our National Council of Persons with Disabilities, they look at developmental as autism, epilepsy, cerebral palsy, ADHD, and so on. So, but generally, regardless of where people feel they fit more, because usually it depends on the spectrum, then you'll have developmental, intellectual, cognitive, which is especially dementia, and a bit of epilepsy, and which is the other one? Developmental, intellectual, psychosocial. Psychosocial is now bipolar, schizophrenia, etc. So the difference is the model. So mental illness is within the health model. Intellectual disability is within so they are covered, and because we need health services, so they are covered in mental, neurological, substance use within Ministry of Health, and therefore that I've said under disability. Genetics do contribute. In fact, the main issues that have been highlighted more are the issue of genetics. Even in my own family, we have quite a few, and it doesn't mean that if my mother has epilepsy, I'll have epilepsy. It could be any, and sometimes it will even jump a generation and go to the next one. Next. So yes, there is the genetics, there's substance use, there's trauma. Those are the ones that are, very prominent. Other than structural facilities, how are the services at Mathare? Hey, that one needs a webinar. Number one, the nurses at Mathare are the best in this country. The very best in this country. They are kind. I mean, I've been to Bustani, which is the most expensive we have now. When I had the insurance, I've been to Oasis, for other issues in the family, because between my parents and I, we have 7 NCDs. So within the different hospitals, I can tell you, Mathare has very good staff. The medicines I've talked about, first generation medication, which is very has many bad side effects. The environment, there are no vocational activity. I think once a week we go to skip in the field and run skipping, because Yes, Harrison?
Sorry, you are breaking while we're speaking about the medicines.
Oh, okay, sorry. Apart from structural facilities, the human resource is good, but understaffed. So like I said, we don't have a single psychologist at Madare. The nurses are so few that in the evening, hey, so we wake up at 8, I think we take porridge. Okay, those who are bright like me wake up at 7 to help the people wash, so that at least they ask for volunteers to wash. So I volunteer with another 3 people. We offer to help in washing, so that at least we can give a Dettol to clean the bucket and then shower in dignity as 3 women. Because now 80 women will come out and try to shower in a very small cubicle, and it's very, very depressing. The sanitation is terrible. There are no vocational activities, so we go to the field, I think, visit once or twice a week. So we just run around the field, play with balls and ropes, but the rest of the time we sit. We wake up at 8, we take tea, we sit. We take porridge, we sit. We have our visitors at 1, we take lunch, we sit. At 3, we take supper. At 3:34, we take our medication. By 5, we are locked up for 15 hours until the following day. Yeah, so I can't remember anything else. You can put it in the questions if I've not covered something. Could you provide us with the 24 other for hospitals that are around? Yes, it's 26. We will, please, Harrison, remind me to include that list. But remember, some are not adequately, but I'll give you the list from the Ministry of Health. What are the stages of mental illness? My goodness, stages. I don't know how to answer that. But if I was just to say from my personal experience, I think for a long time I would do things and people would assume that's my character or my personality. And then these issues would just sort of escalate and so on. So I don't have the right answer to that question, but I'll look for it and include it. So with this information and looking at social and other determinants of mental health, with this information and looking at social and other determinants of mental ill health means that every one of us is susceptible to mental ill health. Yes, you are a candidate at any time, at any place, from any tribe, from any social status. You are a candidate at all times. And that's why I'm telling you, we need you to take care of yourself. We don't want to invite you on this side of ours. Even if we are bright and we are brilliant, prevention is better than cure. Next slide. Is mental health issue associated with witchcraft? Yes, in this country, definitely, because in our Kenyan cultural context, and I encourage you to read the report which we'll share with you, because on page 77 to 79, we as patients and caregivers across autism, cerebral palsy, ADHD, epilepsy, anxiety, bipolar, schizophrenia, dementia, epilepsy, came together and wrote down what our issues are. And the first thing was that, we are assumed to be, to either be cursed or bewitched or mad or dangerous or unable to make decisions. And that now affects the way that we are viewed in this country. And so, yes, it is viewed as whatever, as witchcraft. In Kwale here many people, oh, you're in Kwale, wow, thank you. Kwale here, many people with mental problems are not taken to health facilities because the country believes that it is witchcraft. And that's why we are saying that there is informal care, because whether we like it or not, these people are going to the traditional healer. So what we're saying is we need traditional healers to understand the basics. And the World Health Organization has come up with a mental health gap action plan for low and middle income countries that is targeted to non-specialists like you. Even the media, as you're interviewing someone, you would be able to know 3 things, simple things: what to look for, how to listen, who to link to, because we need our traditional healers, our pastors, our sheikhs, our policemen, our prison officers to know what is mental illness, so that you're able to pass. So we are saying that it is done, but they should learn how to refer. In addition to Caroline's question, why do you find some places, Boy Mariakani has more people with mental illness, and upon asking some residents, it comes seasonally. Yes. Actually, there's something called seasonal affective disorder. It's more pronounced in Western countries because their seasons are very pronounced. You know, their winter is very cold there. So you'll find in certain seasons we get sick more. In fact, I'm a board member of a school for children with intellectual disabilities for the last 10 years. And during the cold season, our kids really struggle. So yes, there's a relation between the seasons, the temperature, and so on, and how it impacts mental illness. Okay, next slide. Can we say then, in order to manage and avoid mental ill health, thank you for wording it correctly, is make visitation to counselors, psychiatrists for mental health checkup regular, just as we do for mental health? Yes. However, just in the same way that we hear that many of our men, when they get to the HIV clinic, when they are the next person, they suddenly want to buy a newspaper. That is the same thing, the same feeling we have when we are going to see a psychiatrist. Because, you know, just like with HIV, even if you got HIV through a dentist, your morality will be questioned. And so when you're outside a psychiatrist's office, you're facing your identity, where now you wonder, these things that I've achieved that are big, are they due to mental illness, as a result of mental illness, or what in me is mental illness? What part of my mind is sane? What part of my mind is not sane? You know, so what I encourage you, which I'm very fortunate to have happened to me, is to send someone to a psychologist. And I don't want to use the word counselor because I mean, okay, we are pushing for the regulation of counselors, so that at least there's somewhere where you can go and see there's a list of people. These ones are, you know, can handle this. These ones can handle this, because many counselors, you know, their training does not include mental health, but psychologists, degree and above, usually it does. However, we have people who have trained as lay counselors or lay leaders, so they're still able to help. So what I encourage is send someone to a psychologist. A psychologist will be able to see, okay, what level of spectrum are you? Is what you're going through possible to deal with in psychology alone? Do you need a specialist? Do you need a psychiatrist? Do you need a neurologist? Because I have bipolar disorder. That's a mood disorder. And that means, I mean, I could be happy for no reason, sad for no reason. I can wake up and feel I am mourning for someone very close and nothing has happened. And those same, those symptoms can be bipolar. They can be due to a brain injury. So I actually went for an MRI to rule it out first. And they can be due to a thyroid. And so in the same way that a psychiatrist is able to rule that out, we need a psychologist before that to be able to see, do you need only counseling, or do I need to send you to a specialist? And if a specialist, which one? Okay. What would be causes of mental health in children? Okay. Bipolar, schizophrenia, anxiety, blah, 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 are psychosocial conditions. These are psychological issues that have been caused by social environments. And so a lot, I don't know why, but a lot of it starts around college age, 19, around there. But we have some children who go through the same psychosocial issues, but at a much lower percentage. One thing that we covered last week, but when we were covering special population disseminating to the public, was that some of the symptoms in children are even bedwetting, probably prolonged, or sudden bedwetting and the child had stopped, or behavior issues that are not, characteristic of this child. And so, in fact, we were saying that many of the symptoms that children have are they are treated as physical symptoms. I talked of psychosomatic, because even doctors usually do not know how to diagnose mental health in children. And by the way, even our nurses, I think probably some medicine schools, but we have many doctors because I went to many who didn't realize I had a mental health issue, and there are many nurses and clinical officers. Mental health is not part of their curriculum, so we are pushing for that as a basic, so that even when a woman has gone for maternal child health clinic for the weighing of the child, the nurses are able to go beyond, weighing the child, to asking, how are you feeling? How are you overwhelmed by your child? Have you seen something strange? Because the first time I started realizing mental health conditions in prison, I met 3 different women who had all killed their children, and those are the small percentage of violence, small. And all of them were saying, mimi nilirusha mamba kwa maji, mimi sikuwa mtoto wangu. Another one was saying, mimi niliona nyoka kwa show, nikaua. Mimi niliona. And when you talk to them, these are issues that started probably even during pregnancy. They started feeling funny, or once the child, was born, they said, saying, hey, this child is changing, and they are not able to say it. Yet this person has gone for clinics for 2 years, and no one realized or asked, And even for children, developmental disabilities and even intellectual disabilities are mostly seen during that maternal child health care. So because developmental is that this child has not followed the usual milestones. So those delays, depending on how much this delay is, then translate into, if it is Down syndrome, usually it starts as a heart issue, it's a chromosome issue. If it is autism is a social disorder, so it affects the social. So physically, this child will have the right milestones, but they don't know that when you put your hand, you're saying greet, or when people sit down, that's a social cue. They are not able to understand that. Okay, can a person realize himself or herself that they're having a mental illness or issue? Yes and no. You probably have seen, the Johari window, which is not psychiatry per se, but there's that part of ourselves that we know. There's that part of that we know and people know. There's that part of ourselves that we know, but people don't know. There's that part of ourselves that people know and we do not know, and there's now a blind spot. So even for me, there are times I can tell, I am a little off, but there are times the people around me are the ones who will tell me, hey, no, umekuwa hyper, So it's good to have a proper balance of knowing yourself, know thyself, and then also having people around you that can easily approach you and tell you when something is off. And especially if you start support groups as media people, then even then, as you become more aware of what mental conditions are, what the symptoms are, it will be easier to pick from your colleagues. I didn't get the presenter right. How is mental health associated with witchcraft in terms of causation or perception? Okay. I don't have a qualified research on this. So just like you've said, a lot of issues are around perception. So I cannot with authority say, especially in a country like our own, that this mental illness was caused by witchcraft, or this person who went to a witch doctor with a mental illness and they seem to be fine. So I haven't seen the research around that. The only thing I can confirm is that there is a big correlation between witchcraft and mental illness, especially the more rural we are, the higher the issues are there. But what I can tell you for sure is that because of the issue of change of mood, thought, and behavior, and especially psychosis, schizophrenia, etc., where people see, hear, or believe something that's not true. I mean, you hear someone having a delusion that they are aliens, and I mean, I not confirm or deny that they are aliens, but a religious leader will look at this as a vision. A person with witchcraft will see it maybe, I don't know, as a dream or whatever. And then a psychologist would be able to see that as psychosis. So what we are saying is psychiatry is a practice, psychology is a practice. They are best placed to look at, where you are. While intellectual disability includes cerebral palsy, autism, Down syndrome, etc. This category 1 is born with either generic and can be managed and not healed completely. I don't quite get the question. Can be managed or not healed completely. Okay, the reason why we call these conditions is because a lot of them fall under chronic. It's like the way we have diabetes. We don't treat diabetes to heal, we treat diabetes to manage. And so in the same way, even for the ones you've mentioned, and by the way, you'll have some people with cerebral palsy, you know, identifying as developmental, some will identify as intellectual, autism, the same, epilepsy, a lot of them identify with neurology, but some of them, you know, identify as mental. So you might hear a bit of confusion with different people. But all of these are conditions to be managed in the long term, and they vary. So one person's experience with epilepsy will not be exactly the same as with someone else. But we need people to move from this issue of saying being healed. Me, I can't tell you how many times I've been told you will be healed in Jesus' name. This is a condition, it's to be managed. We've been advised to say died by suicide, not committed suicide. True. How far are we as a country from decriminalizing suicide? The language of changing to died by suicide, and thank you for that question, is because when we say committed, we criminalize it through language. How far we are as a country, we've talked of legislative reforms. And by the way, I would love to really insist that the change in managing mental health as a country is not just a health problem, it's also a legal problem. Because when we criminalize suicide, then we make it a crime. You know, how far are we? It is in progress because it is being addressed through the WHO Quality Rights Program. Senator Kasanga is pushing the mental health bill, and it includes decriminalization. As a task force, we've spoken very strongly about decriminalizing. So we need your help in pushing for these issues, because the more noise that is there, the more they will be actioned. So yeah, so all I'm saying is decriminalizing suicide is just as important as decriminalizing petty offenses, especially in relation to substance use, is just as important as teaching our children in the curriculum. Mental health is just as important as educating our traditional healers and religious leaders, is just as important as integrating mental health in NCD care, is just as important as dealing with the trauma that you as our journalists are going through, and so on. Do we have adequate qualified personnel in the mental health subsector? No. I can send you the figures for what we have. I think the last figure for psychiatrists was 99. And I think we've been told probably another 100 psychiatrists should be graduating in the next 3 years. We have many more psychologists who are qualified but not employed. So we don't have enough staff in this country. But like I said, we need more of basic information, like I talked about the mental health gap action plan, non-specialized, so that the kawaida person is able to identify early, so that we don't have to go through these 10 years that it will be diagnosed after 10 years when it's serious. So yes. What was the other question? This is the last one, I hope. How can we help to prevent mental health issues in the community? Okay, what are signs you can observe in a person until they have mental illness? Okay, this depends on the specific, and the challenge of mental illness is it's dynamic and complex. So the signs depend on what condition someone had. So I wish we had some time to go through, but there are 2 pages of the mental health gap action plan which we will send to you, and it has the conditions and the symptoms. So for autism, like I said, it's a social disorder, so someone is not able to translate a social cue into communication. Cerebral palsy is this kupooza. In fact, it mostly starts during either pregnancy or during delivery, when the child is denied of oxygen. So it makes the brain palsy, and so it's more physically seen, and most of these children are on a wheelchair. And for children especially, the milestones is where the nurse should be able to detect. ADHD is hyper child. ADHD, attention deficit hyperactivity disorder. So those are the symptoms around that. Epilepsy, yes, we know about the falling down. It's little electric issues within the brain. So there's the falling down, there's the foaming, there's the forgetting where someone is. Anxiety is, we all get anxious at one point or the other, but now anxiety is much greater. So there are people with social anxiety who are not even able to sit, say, in an open office. Depression, that I know you've heard a lot about, worthlessness, feeling worthless, hopeless, being unable to maintain social hygiene, blah, blah, blah. Bipolar is a mood disorder, like I said. So either, very hyper or bipolar is two poles. So there is the high pole of activity, taking dates, bad decisions, etc. The low is the same as depression. Schizophrenia, again, is like psychosis. So you may have someone with bipolar and with psychosis, so it looks like schizophrenia, where you see, feel, or believe something that's not true. See, feel, or believe. And especially for those who, you'll hear someone saying, I'm being tracked by the government, simu yangu inafanya kaka kaka. You only realize this is an issue when someone from Israel says the same thing with someone in Ukambani, and you realize this is actually, an issue with science and so on, and it can be treated. Dementia is progressive. My grandmother had dementia. For older people, it is more common, but there's a lot of forgetfulness that comes with it. So those are a few examples. I'll send you more information. How can we help prevent mental health issues in the community, since it's not easy for people to accept a professional, to access? I think you mean access. Again, I agree with WHO on the GAP action plan for low and middle income countries, which is to educate non-specialists, the public, to be able to see what to look for, what to listen for, who to link to. But basically, the more you get to understand, and I encourage you to have support groups and things like that, learn one thing today, another thing tomorrow. But the first thing is to reduce the stigma in the way we talk about these people, talk about us, sorry. The way we talk about us, the way we view ourselves, to be able to teach children to respect people. I remember the first person who I saw having a mental illness was a lady who was a bride. My mom was taking her through, taking the couple through premarital counseling, and then the day of the wedding, the guy disappeared. And in a week's time, she was totally unwell, and she has never been the same again. But I remember our parents never allowed us to laugh at her or treat her any less than anyone else. So I think when parenting our children, when leading our children, let's lead a generation that learns to respect mental illness, but they learn that through us. So let's know what is right, what is truthful, what is empowering, what is noble, treat us right, give stories of our successes, just the way the West is, showing big personalities who are doing well and they have mental illness. However, there is a worrying trend that Dr. Chite was talking about, that now people are trying to attribute success to mental illness. That is also very dangerous, because we don't want to glorify mental illness. Okay, how can we help prevent mental health issues in the community, since it's not, we've answered that. So that's a dynamic question. All the things that need to be improved, when they improve, they'll help people be able to access. But prevention is key. So when people learn how to do self-care, they'll be able to prevent, even in the rural areas. And we have strengths in the rural areas because of more community, all that is important. How can you help a child who's bedwetting? I'll talk to Dr. Siengo about that. She's very versatile in the area of parenting and psychiatry, so I'll get back to you. Kindly request Charity to elaborate more on self-diagnosis on mental illness if we rely on delusions. Okay, in the era of Google, people diagnose themselves every other day. And I think it's very dangerous. For one, because of that issue of the way there are things you know about yourself and others know. There are things that you don't know about yourself and others know, and so on. And we need to insist that psychology, and I'll insist on psychology more than psychiatry, psychology is a science and an art. And so I encourage people, it's okay to realize that, and since I was in primary, secondary, people keep telling me I'm hyper, maybe I have ADHD. I think it is only natural to see yourself based on the information that you see. But what I would say is have a professional diagnosis. Suspecting is fine, because we have to get to that level of suspecting to start getting help. But self-diagnosis is wrong. We need to learn to work with, even, I mean, like now for me, if I had told myself, hey, I have bipolar, but maybe it was due to a brain injury, the same symptoms, then that means I would be even, looking at who people with bipolar 1, what do they take? People with the bipolar 2, what do they take? And then I treat myself, but I have a brain injury. So let us learn to push people to psychologists, to professionals. And that's why we are saying we do not want to have you have to go to that level 6 or level 4 hospital to get help. And we are pushing for our human resource to be educated on mental health and mental illness, so that even when you just go with pneumonia today and something else tomorrow, that person in that small clinic is able to help you. So I think that's the way I would want to address that question. On self-diagnosis, let's rely on professionals, but that means that our professionals need to be taught. Me, I would hate for another generation to grow up being treated by physical doctors for years before they are diagnosed. I hope I have answered the questions well. Please continue sending them to Harrison. We will, I'll try, put this into a question and answer in the notes that we are going to send to you. Otherwise, thank you for having me. Thank you for listening to us. Please, you have such a wonderful platform to bring us together as persons with lived experience and caregivers. If you deal with someone who's very fresh, tell them it's an opportunity to push for policy. Give them my number, call me. I'm happy to prepare them on what to say so that we have a more impactful, because we are a blue-eyed boy for a very short period as mental health. So let's maximize it. Please take care of yourselves as our journalists. We need you, we love you, we celebrate you. And please portray us as good people, not as villains. Portray us as protagonists, because that will help normalize the mental illness conversation. And mental illness is a non-communicable disease, which is why we are under the Non-Communicable Disease Alliance. So even as I push for more mental health coverage, I also push for non-communicable diseases, because like I said, between my parents and I, we have 7 NCDs. So I need to see more programs on the heart, programs on back problems, blah, blah, blah. Thank you.